Thank you for coming this morning. We're going to get started in about 3 to 5 minutes, so you want to get settled. Anybody that's speaking, please come up and sit by your placard here, and we'll get the meeting started shortly. Again, thank you. And myself, Jenny Jacks, Becky Bunn, we're all here to answer your questions afterwards. If you have any requests, we're happy to try and facilitate them as quickly as possible, okay? Thank you again for coming. We'll get started soon.
They will come, they will sit after the presentation, so, okay. Good morning to everyone, and welcome to this first press conference of the World Lung Cancer Conference 2016. I have the privilege to chair this press conference together with Dr. Robert Pirker, that is the Congress President. Today, the aim of the press conference is to focus mainly in presenting the organization to all of you, and also to address 3 important topics that have been selected by our communication committee for the press release. There are 3 different teams that are telling you one of the unique features of this organization, that is the multidisciplinary approach to educate people and to do research in the field of thoracic malignancies. Let me briefly to tell you what the IASLC is. The International Association for the Study of Lung Cancer is the only global organization dedicated to the study of thoracic malignancies. We started looking specifically to lung cancer, and we felt that it was appropriate to cover all the thoracic malignancies. It was founded in 1974, and now we have more than 6,000 members. You will see in the opening ceremony the right figures, the exact figures of the number of members. We are a global organization because those members are coming from more than 100 countries over the world. So the main aim of the organization is to enhance the understanding of thoracic malignancies among scientists, members in the medical community, and among the public domain. So to do that, we implemented a series of activities. Today I will mention only a few of them. One is our journal. Our journal is the Journal of Thoracic Oncology. It's a peer-reviewed journal. It's already an unbelievable resource for medical specialists and for scientists who are focusing on detection, prevention, diagnosis, and treatment of lung cancer. The impact factor rose significantly across the last years, and now we are in the top 25 of the oncology journals. Or if you prefer, the upper quartile, or any way you want to see the positioning of the journal. We have a mission, and the mission is telling us that we would like to embrace the study about the etiology, epidemiology, prevention, diagnosis, and treatment of all aspects of lung cancer and other thoracic malignancies. More importantly, we are providing education activities and information about lung cancer to all the IASLC members, to the medical community, and more importantly, to our patients. We need to use all available means to eliminate, or let's say, to eradicate lung cancer and other thoracic malignancies as a health threat for all individual patients across the world. This is one of the most important missions that we have. But just to convince you that IASLC is the reference society in the field of thoracic malignancies, I would like to remember you that IASLC is the driving force behind the staging system. We started looking to the staging system more than 10 years ago. We established a specific committee. We founded it with our own money at the beginning, and we were able to be the leader in the field of defining the new staging system. And at this meeting, our committee members will present the 8th edition of the TNM staging system. A lot of people are 100% committed to work for the IASLC. There are a lot of people who wrote books, leaflets, any kind of material, enduring material, and e-material to spread the voice of the IASLC in terms of science, in terms of awareness. I give you just one example. IASLC was the driving force leading the Lung Cancer Awareness Month in November. IASLC was pulling together 25 organizations coming from different areas, just with one specific goal: to increase awareness about lung cancer. We need to do a lot of work because the awareness about lung cancer is much less of the awareness about other types of solid tumors. And I'm not mentioning today expressly breast cancer, but breast cancer is a sort of reference model. Having said that, I can go ahead for other 10 minutes. I would like to remember you that IASLC made a test book that is a multidisciplinary test book that it's already a reference book for many people dealing with diagnosis and treatment of thoracic malignancies. I will be available at the end of this press conference for any question that you would like to pose to myself or to Robert as a Congress President. And now I will switch the microphone to Robert to introduce you the Vienna meeting.
Good morning. Thank you, Giorgio. I welcome you to Vienna. I welcome you to Austria. I'm an Austrian. I was not born in Vienna, but I have become a Viennese, so I know how the Viennese living. And I actually can tell you, we are an important day in Austria, but most probably a much more important day on a global level. We of course have the Austrian elections, which is fine. We will have a president most probably soon, but we have another problem. We have a global problem. We have 1.8 million newly diagnosed lung cancer cases each year on a global level. This is Vienna. So whole of Vienna will be diagnosed with lung cancer, and about 85%, or let's say 1.6 million of Vienna will die each year. So we have a global problem. That's why we are pleased that we can hold the lung cancer conference here. As Giorgio told you, we have a really multidisciplinary conference. And we are involving all the medical disciplines. We are involving patients. We are involving nurses. We are also invite you as the media to help us to transport the most important messages. And yesterday we had a meeting with the WHO leaders on the Framework Convention on Vacuum Control, and we learned that the most important thing is teach doctors, teach the public. So the topics, of course, of the conference will cover active prevention, accurate diagnosis, and advanced care. We are particularly pleased that that the president of Uruguay will actually address the audience tomorrow, and because Uruguay, a small country, has successfully won a lawsuit against Philip Morris International. So he will talk how they implemented the WHO Framework Convention on Tobacco Control. We have, of course, new development in the early diagnosis. So we had a workshop on screening yesterday, and one strategy could be to establish screening early detection units, at least at major centers, and go step by step to improve and to enable early diagnosis, because early diagnosis means more likelihood to be cured, because if you have stage 1 disease, you can get cured in up to 90%. So screening, early detection is useful. We have a new DNM classification, so we will be able to have better classify the tumor based on the extent of the tumor spread, and this will allow a more individualized treatment. And we have more and more molecular based diagnostics, and that will be a major topic here. So we will try to find out more molecular alterations that can be used for diagnostic or prognostic purposes, and most importantly as therapeutic targets in the future. So targeted therapy will be a major issue. The other topic, of course, is immunotherapy. You know, this is a major advance in the systemic treatment of advanced non-small cell cancer, and the future will be to bring these new promising agents in earlier disease stages. We have also, as I mentioned, a multidisciplinary conference. We have radiotherapy, we have oncologists, we have chest physicians, we have medical oncologists, and we together have to provide the best treatment to our patients, and things are improving. So we are step by step, we are improving in all the areas. And the other thing, and that's coming back to the motto, WCLC 2016, together against lung cancer. So we as a global community, beginning from everybody, then doctors, patients, patient advocacy, nurses, and also media and health professionals have to work together to fight a disease that is still devastating, and which on a global level would be preventable in up to 70% of the patients. So I welcome here to Vienna, and I hope that you will help us to promote the messages. We can prevent, we can better diagnose, and we can better treat our patients. So let's now come to the first presentation. It's my long-term colleague from Colorado, from Denver, professor of radio oncology, Laurie Gaspar. She will talk on shared decision-making and patient decision aids in lung cancer. It's a survey of patients, significant others, or caregivers. Laurie, please.
Thank you. Is there something I should do to bring up my slides? Yes, thanks.
To come. By the way, Dr. Laurie Gaspar is board of director is part of the board of directors of the IASLC, just for your information.
Is anything?
Someone be able to make sure that this is coming up?
There is someone.
Can you help us in the back?
It's not that big of a presentation, but.
In the meantime, if you have any question about the IASLC or the meeting, Robert and myself, we are more than happy to answer to your question. Yes, please.
You said before that the awareness for other cancer entities like breast cancer
Well,
comparison with other.
Well, traditionally, you know, when you're looking to the causes of lung cancer, tobacco smoking was and is still today, the cause number one. So it was pretty easy to blame people who smoked that they got cancer because they decided to smoke. And it was much easier to switch the attention to other type of cancers. It was a mistake because today lung cancer is diagnosed also in never smokers, or in, let's say, in former smokers. And the former smokers are today representing the vast majority of the newly diagnosed patients with lung cancer. It's a matter of fact that there were few therapeutic resources up to a few years ago. So consequently, also in terms of research, of new areas of research, there was not too much investments, and consequently, the awareness, the global awareness around lung cancer was quite limited. Sorry. No.
Coming.
It's coming, but...
Somebody.
Can we switch to the second presentation? In the meantime, you are trying to fix it. Because... Can you switch?
You'll be up in someone's in the computer right now, so they'll be looking at it right now.
So, just to conclude my answer to your question, okay? I give you just an example that is related to my country, okay? I'm a soccer fan, and during the summer season, one soccer player moved from Juventus to Manchester United, okay? And they paid 120 millions to move a player from Juventus to Manchester United. My state invested in oncology for the year 2016 only 80 millions of euros. It means that something is moving in the wrong direction. You can release this information as my what? So you don't take your responsibility. Should hopefully work. It's the beauty of the beginning, you know. I mean,
Looks like we're getting close. Seen this one?
the agent is not coming.
There it is.
Okay, fantastic. Wow.
The build-up.
Fine.
Thank you very much. It's really an honor on behalf of my co-authors, Dr. West, Bonnie Adario, who's here today, and Dr. Camage, to present this survey that I did on shared decision-making. So I have no disclosures. So this was a survey that was sent by the internet to patients, caregivers, or significant others who had signed up to receive emails from either the Bonnie Adario Lung Cancer Foundation, GRACE, or the University of Colorado. And I sent out the survey and received 196 anonymous respondents. And in the series of 20 questions, I asked for demographic information. I asked the patient, had they faced a difficult treatment decision, and if they had, how had they made their difficult decision, and how would they have liked the decision to have been made? So of the 196 respondents, primarily the patient was the one who was responding. Because of the advocacy groups that I was sending it through, primarily these were patients or significant others from USA or Canada. They were married, female, white, with the median age of 50 to 60, and were well educated, and the most common situation was that they had stage 4 lung cancer. So there were 60% of patients who said they had faced a difficult decision. I was somewhat surprised, I suppose, that not every patient had faced a difficult decision, but of the 60% who had faced the difficult decision, the most common reason for the difficult decision came around the issue of chemotherapy or targeted therapy. But it was also people who felt that the decision had been difficult when it came to tests that were done or not done, surgical issues, radiation treatment, end-of-life care, or other. And the most significant other, the most common reason, was whether they should participate in a clinical trial or seek a second opinion. So I asked in my survey, the decision was difficult because and then I allowed more than one answer to be given. And the most common problem was that they did not feel that they had enough information to make the decision. Others felt that they had been rushed, heard conflicting opinions from doctors, heard conflicting information from either non-medical sources, and then there's always the issue about disagreement with their significant others or their support team. The amount of information I asked them, the amount of information I had to help me was, and then they could choose one of these answers. So the most common problem was that they didn't know if they had enough information, and that's almost another way of putting that I don't have enough information, perhaps. And 23% of patients felt they had just the right enough information, and this was more significantly said by men. Men felt that they had just the right amount of information compared to women. So the decision was made primarily by, and 23% of respondents felt that they themselves had had to make the decision. 9% felt their doctors had made the decision for them. And then the remainder felt that this had been a shared decision, either with their doctors or with their family or with both. So the majority, approximately 73%, three-quarters, wanted the decision to be a shared decision, whereas only about 50% thought that it was a shared decision. So the main message from this survey that I got was that 60% of patients had faced a difficult decision. There's no significant difference in demographics between those who felt they had had a difficult decision to make and those who had not. Often, there's a perception that there is not enough information there, but this was more of a problem for women than for men. Most patients desire shared decision-making, but only 50% feel that it had occurred in this survey. And they perceive the need for improvements in shared decision. And while time didn't allow me to show you this, I had developed a patient decision aid as an example of how information could be presented. And of people who looked at this survey and answered, they felt that this was a desirable way to go. Despite this problem with difficult decision-making, only 9% of patients actually regretted their decision, which is very gratifying. So I'm hoping that by showing the survey link, which was in my first slide, that I'll have more respondents, because I'm very interested now to know how this type of survey would be answered by patients in other countries. This is an international organization, and I would love to make this survey an international survey. Thank you very much.
Laurie, thank you very much. So
There, so I can see them.
we have now, we open the discussion. So, Laurie, you want to sit here? We have to.
If you want to answer questions,
Just take a seat. So, what you said, information is very important to the patient and shared decision making. So, and it's happening, but there's room for improvement. What is it? Is it time constraints of doctors, or what is the main problem, or what would be the best strategy to improve communication or information?
So this is, I think, what I was getting at with the patient decision aid, because this is a type of aid which is to enable the doctor to, in a reasonable time frame, it only adds approximately 3 minutes to a consultation, that's what the research shows, to have such a decision aid which shows information in a simple visual way, trying to hit at what would be the key elements perhaps that patient needs to understand in order to make a decision between two options.
Okay, questions, please.
What's your feeling
One.
about the conflicting opinions of doctors?
Right.
Now that's 1/3 of the patient.
So the question was about patients being given different opinions by doctors about their treatment. So I don't think there's any way that every doctor should have to see the situation the same. I think the difficulty for a patient is to weigh one doctor's opinion against another. And I think how we get around that at my hospital is to try to meet with a patient in a multidisciplinary clinic where the groups could have, before they go in to see the patient, could have decided what were the reasonable options to present a patient. And I don't believe that there should just be one option necessarily always given to a patient. And so it isn't uncommon for us to have two, maybe three even options for a patient, but try to put them into perspective. And that isn't always easy to do, but I think if we try to come about it with a common message and perhaps trying to rank our opinions, that always helps.
Other questions, please? Please.
There is a question from the back first and then you.
From Sydney, Australia. I'm taking a patient at the moment through this exact difficult decision to the point of tears. One of the common things people are bringing to consultations is media reports about immunotherapy, when in fact chemotherapy is probably the best first-line option for them, but they're overwhelmed by the stigma around chemotherapy. Will you be addressing that in your patient aid, do you think, or something similar?
Well, my patient decision aid that I've so far just been piloting is about a radiation question about prophylactic cranial radiation. But what I'm trying to do is write a grant that involves medical oncologists so that we could address chemotherapy, immunotherapy questions as well, because my interest is not just about radiation oncology, it's about patient decision-making in general, and I agree that that is that's a great example of a difficult decision.
Mitchell Zoller, the oncology report. I guess you give an example, perhaps you could give another one of a difficult decision that patients. Also wondering if you see this challenge specific or becomes more frequent in lung cancer patients.
So there's so many difficult decisions that a patient makes. To find one example of one, I can. So I suppose a patient who's trying to decide whether to go into a clinical trial, I think that to me is a difficult decision, because if you've seen the consent forms for these sort of clinical trials, although the message might be quite clear to a physician, a patient might have an 8-page consent form. And actually, one of my goals with my patient decision aids is to try to simplify that process. That would be one of my long-term goals, so that in a visual format, it'd be easy to understand the consent form, which is supposedly at an understandable level, but is not always. That's I think, comes through, I think, in this survey. And I think your second part of your question was?
Regarding, is this particularly acute problem of cancer, or is it universal?
You know, I only surveyed lung cancer patients, but my suspicion, I'm involved in shared decision-making at my university, and we work with all sorts of other disciplines, and this is a problem for probably all cancers and actually a lot of chronic illnesses as well. It's really a movement of the last few years where the shared decision-making has become its own movement.
Thank you, Laurie.
Thank you.
So in the interest of time, we have to move to the second presentation. And the second presentation is giving you exactly one of the aspects that the IASLC is taking care of. So we are looking to science, we are looking to the advocacy groups, but we are looking also to what our colleagues are doing in the community. And the next presenter, please, Raymond Kane, come to the podium, and is related to the American Lung Cancer Foundation Centers of Excellence model, deliver a standard of care to the community, similar to academic and research centers. This is a critical point because, at least in Europe, but it's the same in the United States, there is still a huge gap in some region between what you can get across academic centers and research centers and what you can get in the community. Right.
Thank you. Good morning, everyone, and thank you for the opportunity to talk today. So I'm going to talk about the ongoing effort that the Bonnie J. Adario Lung Cancer Foundation is making to improve access to high-quality lung cancer care at the community level, and I'm going to just give you a little snippet of what that effort is all about. These are my disclosures. So, lung cancer is the oncologic scourge of our age. Everybody, I think, is aware of that. 1.8 million diagnoses every year, 1.6 million deaths every year. And the bad news is that if you go back 30 years and look at the aggregate survival, we've moved from 12% to about 18% today. And the reasons for that are several. Part of it was the traditional lack of a screening tool in the past. Also, we're discovering heterogeneity in the quality of care that patients receive. Some of these things are changing. We now have a screening tool. We are in the age of molecular discovery in lung cancer with rapidly emerging new tests and new treatments that promise to make a whole world of difference to patient outcomes. But the problem still remains that 80% or more of lung cancer patients, certainly in the United States, receive their care close to home at so-called community cancer centers. These are cancer centers in the United States that are characterized by certain features. They tend to have doctors who are in private practice, so somewhat entrepreneurial physicians. They tend to be more fragmented healthcare systems. There tends to be a broad heterogeneity in the level of detail, knowledge, attention that the doctors pay to lung cancer. And the patients are very diverse. These are patients who tend to be at the lower end of the socioeconomic scale, and they tend to go to these centers because they are closer to them, irrespective of the quality that's available. And there is a lot of work that has been done showing, as Dr. Scaglietti said, the broad heterogeneity in experience of care and outcomes of care that patients receive at these institutions. 80% of the population gets their care in such places. So if you're going to move the needle at the population level and help more people survive lung cancer, it seems that you're going to have to intervene at the level of the places where patients choose to go to receive their care. And the Centers of Excellence program is trying to work from the grassroots upwards to improve the quality of care by identifying community-based healthcare systems that meet certain pre-specified high-level standards of quality. And these standards are based on the acceptance of certain best practices for routine care, such as the use of minimally invasive surgical techniques, minimally invasive staging techniques, and stage-appropriate treatments. The use of interdisciplinary teams, the use of surgeons and pulmonologists and medical oncologists and radiation oncologists and the various different specialists that have a role in lung cancer care up front together before the binding decisions are made in care delivery. so that the patient gets the benefit of the full spectrum of opinion, which hopefully leads to the right thing for the right patient at the right time. But along with that is the need to help patients navigate through these complex healthcare systems, so incorporating the use of patient navigation methods. These institutions also have to make a commitment to screening and the early detection of lung cancer, because we know that that's where ultimately the benefit of survival improvement will come from. They also have to commit to the routine use of our widely and rapidly expanding knowledge on molecular diagnostics and matching patients' lung cancer up with the correct targeted therapy as much as possible. They also commit to making available to patients clinical trials, because again, we are in an age of rapid discovery. And unfortunately, in adult oncology, it's barely 4 or 5% of all cancer patients who actually have been able to participate in clinical trials. And then, finally, the institutions have made a commitment to empower their patients and caregivers by having structured patient information and education campaigns and infrastructure available at all of them. So the presentation I will give, I believe it's on Tuesday, will take a case study approach, presenting 3 model institutions, one out of California, one in Florida, and one in Tennessee, that have used these principles and have results that show significantly better than average expected outcomes for the patient population that they have been able to apply these principles to. What we're trying to achieve here is to have a core set of principles that community-based providers and institutions can subscribe to, including a regime of data collection and monitoring to ensure that we start out right and we stay continuously correct, and then use this vehicle to expand access to other institutions who will then be challenged to join the program, meet the hurdles, and then stay within the group. So we're hoping to use this as a means of providing high-level quality care to patients at the community level and to help eliminate some of the disparities in lung cancer outcomes that have been very well described.
Thank you. I apologize because I made a mistake. I said American instead of Adario, but you know, I mean, yeah, no, just to be, because then they start to say these Italians, you know, I mean, you know. Please.
So how long has the program, Centers of Excellence program, been going on? How many have been recognized?
Thank you for that question. The program is now about 3 years old. There are currently 13 hospitals from 9 states in the United States of America. Some of the institutions are in some of the highest lung cancer incidence and mortality zones of the United States. We're hoping to expand this program as rapidly as feasible.
Situation unique to lung cancer, or 80% of colon cancer patients get their care in limited community settings?
Yes, the problem is not unique to lung cancer, which is exactly why this is such a great idea, because it has legs. It is something that we can perfect in lung cancer, but that can certainly be scaled up across all of oncology. It is also specific to lung cancer, however, because lung cancer is a devil of a problem right now. The disparities in lung cancer care are worse than in most other cancers. There is a prevailing sense of nihilism about lung cancer, ranging from non-treatment of patients, some of whom actually have eminently curable disease, to widely disparate modalities of treatment which may or may not be appropriate, and consequently really wildly disparate outcomes. So lung cancer is a wicked problem, and it seemed like a good place to start.
So just to complement what Raymond said, there is clear evidence across different tumor types that if the patients are treated according to the therapeutic guidelines, the survival expectation is much better than the survival expectation for those who are not treated according to the therapeutic guidelines. So this is the most important message. And this is something that we need to spread as a general information. And you, as journalists, you have a huge commitment in this field. So I see a lot of, again, I'm speaking for Italy. I'm not speaking for United, but I believe that it's the same in the United States. There are a lot of people who are delivering miracles, and they are offering alternative therapies. Well, offering alternative therapies that are not totally proven outside of the context of a clinical study is pretty dangerous. For those fancy doctors that are treating patients in a special way, that are not inside or included in the guidelines, is pretty dangerous. Any additional question for Raymond? Thank you.
Okay, as Dr. Scalera mentioned, the IASLC mission is focusing on all thoracic cancers, conquering thoracic cancers worldwide, and now we are going to another thoracic cancer, mesothelioma, and we have mesothelioma is a major topic also during this World Conference, and activities that are ongoing as part of the World Conference are now summarized. Professor Michel Carbone from the University of Hawaii, please.
Thank you very much. Thank you, Dr. Pirker, first of all, for this beautiful meeting that you organized, perfect organization. Everybody that I talked to is very well happy for everything that we have seen here. As you look at my disclosure on the back, mesothelioma is a cancer that is characteristically associated with asbestos exposure, was a tumor whose incidence was very low until the asbestos industry developed in the past century, and then there has been a tremendous increase in mesothelioma. This increase has been mostly in men who have worked with asbestos. Asbestos has been regulated in the 80s, but we have not seen the decline in mesothelioma that we expected following these regulations. And in fact, in the United States, for example, the incidence of mesothelioma has remained the same since 2000 to now at 3,200 deaths per year. In Europe, continues to increase. While some of these deaths, actually about half of them, are still related to asbestos, past asbestos exposure, we continue to see mesothelioma in people that do not have any reason that we know of to be exposed to asbestos. And so the issue is, how is that they are developing mesothelioma, and what other things are out there that cause mesothelioma? In the past, we have studied an epidemic of mesothelioma in a unique area in Turkey, where 50% of people die of malignant mesothelioma. It's the worst epidemic that ever has been described. No medicine, no disease in the world kills 50% of those affected. The Spanish influenza killed 20% of them. And on the right, you see a family pedigree. Any black dots there are people who have died of malignant mesothelioma in those families. And studying those families, and in the center you can see my office in the village of Saridir to understand how it is that you work in the third world. By studying that epidemic in Cappadocia, we found that that was a genetic disease, and that the susceptibility to mineral fiber carcinogenesis was passed from one family to the next. Those studies then led to the discovery in our lab of BAP1 germline mutation as the cause of the epidemic in some families. In particular, here we studied some American families who were experiencing the same level of mortality. And people who are born with heterozygous germline mutation of BAP1 develop a high rate of mesothelioma, cutaneous melanoma, uveal melanoma, and many other type of cancer, but prevalently cancers that are induced by environmental carcinogens such as asbestos and UV light. And that is because they are much more susceptible, extremely more susceptible to environmental carcinogens. So as we found this well-defined genetic condition that is responsible for a small portion of mesothelioma and melanomas, I have been looking for other unique situations around the world that could allow us to identify other reasons why people may develop mesothelioma, and that's what I'm going to talk in the next few slides. This report is about, that I'm going to present 2 days from now, has been published December 1st, is advanced online in JAMA Oncology, and the other part of it is going to be published in Journal of Thoracic Oncology in press. I do not know when it's going to come out, but the two papers are coming out basically back to back and describe this unique epidemic that we have been studying in China. This is the next paper that is coming out in Journal of Thoracic Oncology. The reported incidence of malignant mesothelioma in China, I have to read there because I can't read this thing, is 1.5 cases per million, much lower than in other countries. In China, the prevalence of mesothelioma in different regions is unknown, and only 50% of mesothelioma have been associated with asbestos exposure compared to over 70% in the rest of the world. During my visit to the Zhejiang Cancer Hospital, which is the largest cancer hospital in the city of Hangzhou, where there is no asbestos industry, I was asked to consult because a patient had just been diagnosed with mesothelioma. I found it was not a mesothelioma, and that started the study to see whether, in fact, mesothelioma was misdiagnosed in China. As I was doing that, then we discovered other things. We reviewed all pleural and peritoneal malignancies diagnosed as mesothelioma during the year 2002-2015 in the Zhejiang Cancer Hospital and in the nearby Yuyao Hospital that is located in the middle of the asbestos industry in China, so where all the patients are in fact exposed to asbestos. There were 92 meso, 34 in the pleura, 56 in the peritoneum, 2 in the tunica vaginalis. When I looked at that, I immediately thought something was wrong, because mesothelioma are much more common in the pleura than in the peritoneum. And in fact, I was wrong. There was nothing wrong with that. It was true. Reviewing the histology with the aid of a large panel of immunohistochemistry, we confirmed the diagnosed in 52 and 92 cases, 56.5. So clearly, there is a lot that needs to be done in China to improve the diagnosis. The male-to-female ratio was approximately 1:4, compared to 4:1 in the US. That is really amazing. The pleural peritoneal ratio was approximately 1:3, compared to 5:1 in the US. That was very unusual. The average age of diagnosis was 50 years compared to 72 in the US. And mesothelioma occurred in 9 out of 50 occur in individuals age 40 or younger, compared to less than 1% in the same group in the US. So you see that you have a different situation here, very different. Asbestos exposure was determined by trained oncologists who interview patients for occupational and family history, individuals who worked in trades where asbestos exposure was likely, or who grew up, lived in families in which others were employed in the textile industry, or trades associated with asbestos were identified as asbestos exposed. So there are very loose criteria to be sure we catch anybody who can be exposed. 20 of 52 mesotheliomas occurred among asbestos exposed individuals, and 2 of 28 were from Zhejiang, and 18 to 24 were from Yuyao. So you see that if you just focus on the Yuyao group, you conclude that all the mesotheliomas are related to asbestos. But then you see that there is the other group in Zhejiang that is getting the same type of disease in the same group of people where there is no asbestos exposure. CT scan available for Zhejiang Cancer Hospital supported asbestos exposure in 2 of 16. So to conclude, the higher prevalence of peritoneal versus pleural mesothelioma in China, especially among non-exposed young women, is unique. Initially, we thought that asbestos was the main cause, as 13 of 18 peritoneal meso from Yuyao occurred in women. However, only 1 in 14 peritoneal meso from Zhejiang was associated with asbestos. Except for asbestos exposure, not significant demographic difference were observed between Zhejiang and Yuyao, suggesting that asbestos may not be the main cause of mesothelioma in these young women. In the US and Europe, there is an increasing number of peritoneal mesothelioma that do not seem associated with asbestos, leading some authors to speculate that a subgroup of peritoneal meso may have a different pathogenesis. our findings point to a unique opportunity to investigate other causes of peritoneal meso in this Chinese population, aside from asbestos, and were identified to implement preventive measures to decrease the incidence in future generations. Basically, we find ourselves in the same situation we were 15 years ago when we found that epidemic of mesothelioma in Cappadocia. We didn't know what it was. We studied that, we found the gene, and then we found the new cancer syndrome. Here we have something completely new and unique, and now we hope to work with our Chinese colleague and find out what's going on, because what is going on there then will inform us about what's happening in these young women in Europe and in the United States who are getting meso in their 40s, and we have no idea why. Thank you.
Thank you, Michele. So, the presentation that Dr. Carbone made, it's a clear example of why the IASLC decided to have a mesothelioma task force, and how much work the IASLC needs to do to spread the educational theme also for mesothelioma. The epidemiology of mesothelioma is pretty different in Europe and in the United States from, for instance, the outstanding work that Michele did in Turkey and what he started doing in China. That means that we need to do a lot of work even in big countries like China to increase awareness about mesothelioma, because it's a sort of black box. We don't know enough about the past history of some countries. And as we did for tobacco smoking, we need to push for the asbestos ban. And I would like to remember you that there are many countries in which asbestos is still mined and is still manufactured. And I would like to avoid to quote specifically some countries, but also well-educated countries are still running the asbestos business. Questions? Bonnie?
You consider an epidemiology study on these women and the people that have no association with asbestos to see if you could find that common denominator?
Yes, we need to do that. We need to study whether, of course, there are genetic factors, that's obvious question, whether there are other toxic substances that can induce that, whether there is, unknown to us, exposure in the environment from which these people are exposed. Obviously, there is something, and for some reason, this something is affecting more women, which is very unique, because in Cappadocia, I had a situation that was one-to-one between men and women, so I knew that everybody had the same thing. Here, instead, we have this very unusual prevalence of cancer that is much more prevalent in men. We have it much more prevalent in women and in a location that is very rare. So it's very unique. There has to be some reason, and we hope to address the reason.
Further questions, please.
Right now you have no information on any family clustering of the cases?
No, at this time I do not have any information.
Please.
Very short question. Can it be maybe related
At this point, any hypothesis is good. I would not rule out any hypothesis. Any hypothesis that somebody comes up with that has any logic or even doesn't requires to be ruled out. Clearly, we have a unique situation, and clearly we do not know why.
What Dr. Carbone made is just a snapshot of a couple of sites, no?
Yes.
We don't know the denominator of the people who were exposed to asbestos or any other factor. So it's a pretty interesting observation.
And especially the fact that we are comparing two groups, one that is heavily exposed and one that is not exposed, then allow us to reach conclusions that otherwise would be difficult.
Okay.
Are there further questions? If not, Professor Carbone, thank you very much.
Thank you so much.
Do we have any other further questions before we close? If not, I thank you very much for coming, also on behalf of Giorgio, on behalf of the IASLC, and I would like to invite you for the next press conference tomorrow and the days after, and I hope that we can work together fighting a global disease. So we need you together against lung cancer. Thank you very much. Thank you. You're welcome. Oh, I see.